but then she did like a 300 countdown, and I got really
okay. So that's in order to get rates. All right. So you know that you've got big boxes,
Those are 0.2.
and then you got small boxes inside them.
I thought they were
Right.
0.4. The little one.
Right. So if you were to look at a QRS that hit here, and then another QRS that hit there, if you count the number of boxes in between, so if you went from here to here, that's 300, a rate of 300. If you went from here to here, that's 150. If you went from here to here, that's 75. And that's how it gives you a ballpark heart rate. All right. Or you just look up at the top and you say, oh, look, it says it's going 78 beats a minute. That's all that is. It's just counting the number of boxes in between R to R, and that tells you your approximate heart rate.
I thought you just counted the R's and then times it by.
You can do that too.
Yeah, that seems way easier.
It depends on how much of a rhythm strip you got.
Okay.
Okay.
Right. I mean, I guess if you have a pretty.
Yeah, and they say that you really need 10 seconds of a rhythm strip in order to really interpret a rhythm. Okay. Because how do you interpret a rhythm when you only have 2 beats? It's not really much of a rhythm, is it? Not much of a pattern. You know, I don't identify a song listening to one. What's the name of that song? I don't frickin' know, right? I need more than that, right? How do you identify a rhythm if you don't have a few beats, right? But ultimately, I can take a rhythm that's 3 beats long, and I can say, okay, my approximate heart rate is this. That's how you do it.
Okay.
All right. What else? That's it? 2 topics? Wow, this is going to be a short night. All right. So, and these I'll tell you, honestly, God, I've been doing this now for a few years. These are the 2 questions that I get every time. I never get anything else. They all stem off from that. All right. So, let's get rid of your wheelie chair here. First of all, while we're giving a few minutes, let me introduce myself. First of all, yes, my name is Guy. My parents were caught off guard when I was born, I think. They said, well, it's a boy. What are we gonna name him? Well, we can't call him boy, so we'll just call him Guy. When my sister was born, they were caught off guard again. So like, girl? So we have Guy and girl. Yeah.
Your sister's name is really Girl? Are you lying?
Of course I am. It's for a fun story. So the whole Mr. Rogers thing just does not work for me. So it's just Guy, and I work as a physician assistant, so there's no doctor or anything else in my name. Okay, so it's Guy. As I said, I work as a PA. I work in cardiology here. I have kind of a unique job. I'm what I refer to as a plumber. So I'm an interventional cardiology person. So I deal with heart disease, heart failure, peripheral vascular disease, valvular disease. I'm not an electrician, so I don't treat a lot of rhythm issues, even though we're all trained in some basics treatment of it. I don't do pacemakers and defibrillators and that stuff. I leave that up to the electrical guys, all right? I've been in cardiology here for 17 years. Prior to that, in my former life, I worked as a paramedic for about 15 years. Before I went back to school. I am not a nurse, okay? My mom was a nurse, God bless her to death, could not do her job one bit. I applaud you all greatly, that's just not my thing. So if I step over the line and I insult you, I apologize, and I didn't mean to, but I'll try not to. One of your classmates knows me from teaching 12-lead interpretation. Going to paramedic school as well. I'm a real down-to-earth guy. I like working with my hands. I'm very mechanical. That's the way I teach things a lot. If you're not very mechanically inclined, you know, do your best you can.
So how'd you get to be an NP?
How do you get to be an NP?
Well, yeah,
Okay.
because they're gonna have to further their education.
So-
This is an associate's degree.
Right. So in order to become an NP, you have to have a bachelor's degree to begin with, and then you apply to an NP program. An NP program is now a doctorate program. So they'll either require a master's before you come in, or you'll have a program that'll take you through a master's and then a doctorate in order to be an NP, which I don't really understand. Because if you think about this, a nurse practitioner, unlike a physician assistant, we are tied to a physician, okay? We have to have a colleague relationship with a physician. I cannot work without a physician. A nurse practitioner is an independent practitioner. They can hang their own shingle up, they can own their own business, they can treat patients. They have to have a collaborative agreement with a physician, which means that they have to have a physician that they can call if they have questions. But that physician could be in another country, just available to them, right? So if a nurse practitioner is required to be a doctorate, and they can hang their own shingle, what do you call them? Doctor, right? Are they a physician? No.
Or doctor of
They're
nurse
not.
practice.
It's a PhD. They're not a medical doctor, right? But does the average population know that?
No.
Do they understand the difference? No. No. Problem with it, and I work with a lot, as a matter of fact, I'm the token PA in my office. I'm the only PA. I have multiple other nurse practitioners that I work with, and I love them to death. They're great to work with. Training is different. When you go to NP school, they don't teach you to be a practitioner. They take your experience as a nurse and they say, okay, well, here's how you prescribe, right? And here's a little bit more about testing, and here's how to read research papers, and here's how to write papers, and we're gonna send you out to see how other people practice, but they don't teach you to be a practitioner. So when you come out of NP school, it's really based on whatever experience you've had as a nurse. So if you spent a lot of time, like my coworker, she was a cardiac nurse up on, it used to be 6 North, our cardiac telemetry unit, and she was there for a good number of years before she went back to NP school, and she went right into cardiology, because that's what they do. We had another nurse that's a friend of mine, she worked in ICU, she came out, she went to orthopedics, knew nothing. Was completely just blown away, and she's like, I don't know how to do any of this stuff. I don't know this terminology, I don't know the anatomy, I don't know any of that stuff, because they didn't get that. But now you can go, you can be in your own private practice as a nurse with your nursing experience, and you're called doctor. With no physician there. That just seems like it presents a lot of liability. But not that I'd say that it might not work, it's just that I'm a little nervous about that. So let's talk about rhythm interpretation. Do you guys learn the 5-step or 7-step rule to identifying rhythm?
5.
5 steps? Okay, do you remember them?
Yeah.
What's step number 1?
Is there a Q wave?
No.
No, that's not the first one. The first one's rhythm.
Right.
Rate.
And then rhythm.
Rate first.
And then P wave.
Rate. So what about rate?
Is it normal?
Okay. What? I don't like to call it normal. I don't like to use normal.
Is there a P wave for a Qrs?
No, we're talking about rate.
Oh.
So something simpler. Is it fast or slow? Okay. The reason why you could throw normal in there because it's in between fast and slow, but ultimately is it fast? Is it greater than 100 or less than 60? Right? You could say if you want to throw in there normal, I guess you can. I just don't like the word normal. Because normal for you may be different from normal for somebody else. Right? So that's first. Okay. What's next?
Rhythm.
Rhythm. Okay. Now, I am, like I said, a real down-to-earth person. I don't mind admitting to my shortfalls. Spelling is atrocious. Okay? And for some reason, rhythm does not make sense to me when you spell it out. So help me out.
R-H-Y.
R-H-Y.
T-H-M.
T-H-M. For some reason, I like to stick an extra Y in the wrong spot or whatever. So what about rhythm?
Are the R waves regular?
Okay, so we'll just call it regular, right?
Mm-hmm.
Or
Irregular?
irregular. And what about irregular? So can it be regularly irregular
Yeah, are they like all?
or irregularly irregular?
Yeah.
Right? So with that, there's regular and there's irregular. You understand the difference between the two? Regular, irregular, and irregular, irregular, right? I don't want to assume anything, all right? What's next?
Q wave,
P? What about P waves?
are they present?
All right, so P or Qs and Qs or Ps, right?
I don't know what that means.
Okay, so if I have P, QRS, T, correct? I have QRS, T, QRS, T, P, P. Do I have a P for every QRS? No. Do I have a QRS for every P? Well, there's a QRS for that P. Oh, there's QRS, there's no P. Oh, there's a QRS, there's a P with no QRS. So is there a P for every QRS and a QRS for every P? That'll come about here in a minute when we start reviewing it and what that means. And what we'll do is we'll throw some examples of what I'm talking about. All right, so what's next?
QR interval,
Or intervals. Intervals, what intervals are you interested in? PR interval. PRI, okay, which is really the big interval because really does the QRS interval help you identify a rhythm? Only in probably one specific case, and that's about it, all right? But really you're interested in the PR interval, right? And if I were to ask you right off the bat, in what you've learned so far, in what rhythm is the PR interval most important? Oh. Jump too quick. Okay, we'll just let it go. So you can number this as 4, you can number this one as 5, however you want to do it. That's usually the 5-step approach.
so R5 is QRS complex.
Okay, so what about the QRS complex? QRS interval?
Yeah,
Oh, why
to
it is?
measure from the beginning to
Yeah.
Q to the end of S.
Well, yeah, that's what I was saying. The QRS interval really doesn't help you identify a rhythm except in one case. Like if you're identifying VTAC. Okay, that's the only time a QRS interval is of any use whatsoever. So, I mean, you could throw that in there.
And VTAC is pretty obvious to identify.
It is, but it isn't, okay? The basic pattern of it will be fairly easy to identify. However, it becomes even more complicated. But really, in the circumstances where we have people who have wide complexes, like bundle branch blocks, okay? When you're identifying a rhythm, does the bundle branch block help you in identifying the rhythm? Does it hurt you? No, it has no impact whatsoever. So does the QRS width really make a difference in identifying a rhythm? Really doesn't. The PR interval does. I'll tell you in particular, in first degree heart block, that's where it becomes most important. Any other rhythm, it doesn't really help you. All right, so QRS, yeah, if you want to put it down there, but it really doesn't help you. Okay, so that's the 5-step approach. What you need to remember is that this is a system. If you stick to the system always works. Okay? You have to do these steps every single time. When you're learning your rhythms, you guys, did they get a rhythm interpretation book? By
No.
chance? Okay, I'm gonna give you a couple names of authors, okay? If you can get a hold of a Dubins or Walraven, both of them in the back of them have like 3x5 cards that you can, they're perforated, that you can pull out. And on the front of the 3x5 card, you can make these if you want. On the front of it is a sample of a rhythm. On the back are the answers to these 5 questions. The reason being is there is a process of elimination that if you answer all of these questions properly, There's only one rhythm it can be, because you eliminate all the others by answering these questions. Give you an example. All right, we have T, P, QRS, T, P, QRS, T. Somebody asked this before. Let's talk about normals, all right? This is called a P. This is a T. Now, I have not labeled your QRS in there, because we're going to talk about that in a minute. Okay. If this ever gets out, you know where it came from. Okay? Cardiologists are not very bright. Okay? This is a P, right? What comes after P?
Q,
And what comes after Q?
R,
What comes to that?
S,
What comes after that?
T,
And what comes after T?
U.
Right. So why did they call them P, Q, R, S, T, U?
I can't forget it.
Because they're in alphabetical order. But why did they start in the middle of the alphabet? Why not call it A, B, C, D, E, F? They're not very bright.
Hi. I'm late. I'm late to class.
We'll excuse you once,
I brought pizza too.
not twice.
Sorry.
No, it's all right. So now,
Jackie got up.
so this is going to come back again where you're going to find out that cardiologists are not very bright. All right, so now,
Oh, we're sitting here?
No.
let's define a couple things. First of all, what if I was to tell you that not everybody has a QRS complex?
I'll believe it.
You would or wouldn't?
I would.
You would? Okay. Why do I say that?
Because people can die.
Not every living person has a QRS complex. I'm going to even tell you that there is not a single QRS complex on this board.
Oh, I don't understand.
Okay? So now, why do I say that? Because let's define what a QRS complex is. So let's say here's the P wave, right? You have negative, you have neutral, isoelectric, no electrical activity, right? Now, if your impulse immediately after the P wave goes negative,
That's where your Q wave starts.
that's the beginning of a Q wave. It has to go negative. If it goes P and positive, it's not a Q,
Right.
it's an R. Okay?
Is that why they call it the PR interval rather than the?
PQ,
Yeah.
correct,
Okay.
okay? And even to call it a
Does
PR,
that really bother me?
Yeah.
even a PR is not appropriate,
I feel
because
like
it
I
really
never
is
even
the
noticed that they
P
skipped
to
Q.
the first positive or negative inflection. Okay? So you're measuring from here, actually you're measuring from the beginning of the P to there. That's your PR interval. Or you're going from here to here. It's after isoelectric is the ending of your PR interval. So a Q begins if it goes negative, and R is if it goes positive. Continuing on, S is when it goes back through isoelectric. Okay? Back to isoelectric. All right? And a T is where it repolarizes. Now, some people will come up here and then come back, in which case this is a Q, and then you've got, you have R coming up here and S coming back down. This is an R, and then coming back up, this is an R, S, R prime. Yes, ma'am?
So when I was reading yesterday, there was, one of the waves has to do another, hold on, I have to think of what the word was. Is it a deceleration? I don't remember what the actual figurative language is, but it was after, it's after like your R, I don't know if it was your S or your T, but there has to be a decel before it can be considered.
So, it has to, so, if you have a P and it goes negative to here,
Yep,
okay?
so that's your Q, but I thought it was after that.
Correct. If it goes up again,
Yep.
that's an R.
Mm-hmm.
And when it comes back, it decelerates again, that becomes an S.
Uh-huh.
All right? And then you have a T. Okay?
So your T has to,
If it never goes positive again, that's all one Q wave.
okay,
There's no QRS.
okay.
And I've seen that.
Mhm.
I just got.
Yeah, we're gonna get there. All right? So this is a Q, R, and people will label it an S wave or a QR wave. All right? So this is a P, R, S, R prime, actually like that. So this is an R, S, R prime. Why do I tell you that? Well, not so much to get you confused or trying to identify the waves and such. It's in particular is to be able to identify that. Q waves, okay? Not everybody has them. Some people do, some people don't. What's the importance of them? Well, there's two types of Q waves. There's good ones and bad ones. So a Q wave that is small and narrow is normal. Okay? A Q wave that is deep and wide is abnormal. Okay? Now, abnormal what? Well, we have two types of Q waves. There's the physiological and pathological. Now, if I go to the operating room and I take a biopsy of something, I send it to a department to get it analyzed, right? What's that department called?
A lab
Well, it's a lab, but
or pathology?
it's called a pathology lab. Is the pathology lab looking for normal or abnormal? Abnormalities. So a pathological Q wave is an abnormal Q wave. So if you have a Q wave that is greater than one small box wide, wider than one little box, and deeper than 2/3 the height, that suggests a pathological Q wave. Now, this is what you and I were talking about a few years ago, okay? When you go on to start learning about 12-lead interpretation, you start learning at trying to look for heart attacks, new and old. If you have two pathological Q waves that are in the same area of the heart, they suggest somebody's had an old MI. A physiological one is just normal, you're born with it. You ever heard of anybody saying, oh geez, family member went to the doctor, they looked at their EKG and they said they had an old heart attack?
Yeah.
This is what they're looking at. Okay? It is not pathognomonic. It doesn't mean that every time you see that, they've had an old heart attack. It suggests an old heart attack. My mom said this for years. My mom was an old cardiac, not old. She's a retired, very educated cardiac nurse. She did med surg here for a good number of years. And back in our old days when we used to do heart caps and you'd sit there for 14 hours with a 50-pound sandbag on your groin, my mom said, oh, my doctor told me I had a heart attack and there's no way I'm going through a heart catheterization. And it was probably this day that I felt like crap when I thought I had the flu. I probably had a silent heart attack. Well, it was because she had this type of an EKG change. When she did ultimately get a heart catheterization, she had no disease. Echocardiogram, stone cold normal. She had never had a heart attack. But her doctor interpreted her EKG suggesting an old heart attack. All right? So, my point to this is Q waves. Not everybody has a Q wave. We need to look at Qrs complexes. Did I get everybody lost on that? No? But that's what a Q wave is. Not everybody has them. Some people just have RS waves. Some people have Q waves. Some people have RSR prime waves. Doesn't matter. But ultimately, deep and wide Q waves are potentially concerning. Okay? We good? more food. No, don't eat more food, that'll put you to sleep. Okay, so, somebody asked about what is intervals, okay? So PR interval is from here to here. Whether this goes positive or negative, it is the first inflection after the isoelectric line after the P, okay? What is normal? What's a normal PR interval?
0.12.
No, 0.6. 0.06 to 0.12.
No. You're thinking of the QRS complex. PR interval is here,
It's come up again.
less than 0.20, 200 milliseconds, or 5 small boxes. QRS complex from here to here should be less than 120 milliseconds. However, in cardiology, we actually say it should be less than 90 milliseconds. Anything beyond from 90 to 120 is an incomplete or a intraventricular conduction delay. It can be an incomplete bundle branch block, it can be a vesicular block, it can be anything that delays the conduction through the QRS complex. So, 120 milliseconds. How many small boxes? Needs to be less than 3. 3 small boxes. Let's talk about that for a second. Where does that number come from and why is it significant? You've heard about bundle branch blocks, right? How many of you can identify bundle branch blocks by looking for the bunny ears?
I look at the interpretation on how
She sat through my class before. Usually I get, oh, it's because of the bunny ears. Well, that's not true. It needs to be greater than 120 milliseconds by reading the top of the EKG, because you can see the QRS duration. So here's how it works. Okay, don't laugh at my artwork either. That's a heart. Okay, so where's your P wave? Where is your SA node?
Right atrium.
Radiatrium. So the radiatrium fires. Okay, now I'm going to draw a couple of things on here. When we look at EKG paper, it's graph paper, right? So we have neutral to 0, no electrical activity. So if something moves up on a graph paper, is it moving positive or negative? So if it's going up, is it going in a positive direction or a negative direction?
Positive.
On a positive direction. And if it goes down, it's going in a negative direction. So now let's take this part and let's attach some electrodes to it, right? So let's put a positive electrode here. We're going to put a negative electrode here, right? So we do what's called vectors or combined forces. If you look at the SA node, when it fires, it sends off a wave of electricity, correct? Around like so. So if you combined all of those together, in general, which direction, positive or negative, is it heading?
Positive.
Going towards a positive direction. So, and are these big chambers or small chambers? I need more people to answer questions than just 2. Come on, gang. So, it makes a small wave in a positive direction. It comes down here and it pauses. What's that? AV node, awesome. So the AV node. That's AV node. So it pauses in the AV node and you get a flat line, correct? Okay. Once it fires from there, it goes on a short stalk called your bundle of His and then splits into 2. Here and here. These are your bundle branches. So if it's firing down and now there's combined forces, are going negative or positive? Positive, so it goes up, right? Comes around here and wraps in this direction. So now which direction is it going?
Negative.
Negative, right? Gets out here in the branches.
Oh my god, this is making more sense already.
And it stops, right? So the electricity stops, so it comes back to neutral. And then the system has to recharge, right? So where it recharges is your T wave. And that's why we get that shape. Does that make sense?
Yeah.
Okay.
Actually,
See, like I said, cardiology's
yeah,
not that
it
right.
does.
Alright?
So
If
what
I could
causes the
understand
U
this.
wave?
What's that?
What causes the U waves then?
So a U wave is an electrical phenomenon. Okay, it can be caused by electrolyte abnormalities, can be caused by lots of things. It has no clinical significance whatsoever. Okay, some people have them, some people don't. If we see them there, we're like, that's a U wave. We ignore it.
Thanks, Jess.
Okay.
It was one of our questions.
Yeah.
That got it wrong. So we were
I mean, if your professors want to test you on it, well, that's great.
We didn't even learn it.
It was with hypo.
I thought she was full of crap.
Okay.
I'm like,
Yeah.
really?
The problem is
There's
if you
such
look
thing
up
as a
causes-
U
And
wave?
that's what I thought too.
I saw it on the.
There are
nursing
lots of
central
causes for
thing,
U
but-
waves. One of which might be an electrolyte problem. All right, so you can list hypocalcemia, you can hypomagnesia, you can list all kinds of different electrolyte abnormalities, or you can just say it's benign. It's just there, and all our electrolytes are normal. So it's really kind of a stupid question. Okay, let's talk about this. All right, so we all saw normal, right? So we're going to create the same thing. Fires the SA node, we get a small P wave, right? Now let's pretend the electricity changes a little bit. Let's block the electrical system there, okay? So it fires from the AB node, so we get a pause. Fires down here, hits this block, but this one continues to fire. So is the electricity going in a positive or negative direction? Going positive, because it's firing down here. It goes this direction, right? Comes down here and loops this direction. So go negative or positive? Negative, okay? So, but this side still has to fire, right? Well, it can't just leave it there, so the electricity comes back. Goes this direction, positive or negative? Positive. Comes around here and wraps around this side. Now which direction?
Negative.
Negative. Now, does it make sense that if the normal time frame is less than 120 milliseconds, it's going to take longer to go over here and come all the way back, right? So if I have a bundle branch block, by definition, my QRS has to be greater than normal, greater than 120 milliseconds. Regardless of the shape of it, it has to be greater than 120 milliseconds. Well, if you look at an EKG, you can see that right up in the top box. It gives you a whole bunch of numbers, one of which is QRS duration, right? So now, I'm going to throw something at you. I know this is advanced, but just bear with me, okay? Again, you're all just not very bright, okay? Now, you know that there's a difference between lefts and right, right? I'm going to teach you how to tell the difference between the two very, very easily. But you have to have a 12 lead to do it, okay? So if you identify, oh, this one's got to pick up a 12 lead, right? I don't know how to read 12 leads yet, but it's got a whole bunch of stuff on it. Oh, numbers, oh, QRS, greater than 120. Guy told me that's a bundle branch block. Okay, so go to lead V1. Okay, every single time, look at the shape of the QRS complex. Here to here, okay? Everywhere that you see a spike, put an arrow on it. So here's an arrow up, arrow down, arrow up. Everybody see that? Okay. Pick the last arrow. Which direction is it going?
Up.
Up, okay. I want everybody to put your pens down. Okay, turn around, face your table. Reach out and grab your steering wheel. All right? Come on, you gotta do it with me. All right, you already got the steering wheel. Where's your turn signal?
Right here.
All right, turn signal's over here. If I turn my turn signal up, which direction am I turning my car?
Right.
You have identified.
It took me a second.
If I turn it up, I'm going to the right. If I turn it down, I'm going to the left.
Are you sure?
Yeah.
Is your turn signal on the left or is it on the right?
It's on my right side.
It's on the right. If I turn my turn signal up,
Where is your turn signal? It's on my right hand side. I don't believe you.
it's not, it's on the left.
Oh, okay, I was gonna say.
Are you sure?
Yeah, you're driving and you're like, oh, I gotta go to the right. So you like
I don't know.
I love asking this question because it's amazing. We've all been driving for how many years? We don't know our turn
No,
signal
I
is.
just noticed today that she hits her space bar on her computer with her pointer
On the
finger.
right.
So
No, my lights
you're
are
a little
on the
bit
left.
different.
Leave me alone.
Maybe
Do you do
I
that?
wish
Do
it
you
worked
do
first.
thumb to hit your space bar? Or is on the left? Okay.
Comes with
I mean, if you,
wait, if you type
Typing?
Yeah.
Okay, so when you get in your cars tonight, find where your turn signal is, right? And remember what I say. If I turn it up, I'm making a right turn. If I'm flipping it down, I'm making a left turn. If you go on a 12 lead and somebody's QRS is greater than 120 milliseconds,
What if my car isn't American? Are you sure it still works the same way?
I don't know that, but do you have a non-American car?
Yeah.
In other words, it was shipped here from England.
It's like,
It's an English car.
is
If
it
it's shipped to the United
Japanese?
States, if it's shipped to the United States and
Korean?
sold in the United States, if it's sold in the United States, it has to meet American standard, which means the steering wheel is on the proper side of the car and the turn signal is on the proper side
She's
of the
been
car.
flipping her
Right, but
windshield
are you sure
wipers
that
the
if
whole
I
time.
flip it those ways, it still works the same?
we'll check when we get in your car.
Okay.
So anyways, I digress a little bit. That's just a little bit of fun stuff about cardiology.
I'm just worried.
Let's talk about rhythm
That's right.
interpretation. Okay? So, P,
Well, I remember
QRS,
that. I don't even know.
T. P, QRS, T. All right. So, everybody will probably look at this and say, now assuming that this PR interval is normal and the QRS duration is normal, everybody would say, well, that's a normal sinus rhythm. Well, even normal sinus rhythm meets certain rules. So its rate is not fast or and it's not slow, correct? It's a regular rhythm. I've got a P for every QRS and a QRS for every P. And my PR interval is normal. So does it really matter what my QRS duration is? Is that gonna change the rhythm? It's not. So that's why I don't really include that, all right? I think it just makes things confusing. All right, so it's a normal sinus rhythm because it met that parameter. Let's say the heart rate was 120 beats a minute. It was regular. There's a P for every Q, a Q for every P, and my PR interval was normal. What would that rhythm be?
Sinus tech.
Sinus tach. Why? Because it's got a rate greater than 100. It's regular. So P for every Q, Q for every P, and my PR interval is normal. That's why it's a regular sinus tach, right? So let's move on. Let's say that something has this.
Oh God.
Okay, so what's the rate? Does it look fast?
It looks
No,
slow.
it's
Remember,
Brady.
we're all from R to R. We're looking at the QRS complexes in order to determine rate, okay? So I would say it looks slow. Granted, you only have 3 beats, but it looks slow. Okay, so it's slow. Is it a regular rhythm?
No.
No.
Okay, because you measure regularity by looking at R to R. Is it regular?
Yes.
I don't think so. I think there's different amounts in between each R and R.
trying to freehand it.
Oh, okay. Sorry.
And it looks pretty even to me, even for an amateur artist, okay? All right, so it's slow, it's regular. Is there a P for every QRS?
Yeah.
Yes. Is there a QRS for every P?
No.
No.
Wouldn't it, I have a
No.
question. Wouldn't it be regular?
You're looking at the R to R. In order to determine regularity, you're looking at R to R. That's all you're looking at,
Nothing in between there.
nothing else. When you're trying to determine rhythm, it's R to R,
Okay,
okay?
okay,
So, and we'll get back to this when we start talking about blocks,
okay.
all right? So we're not done yet. So, We answered all PR intervals. Well, the PR interval within normal limits. Well, geez, since there's more P's than there are R's, you can't really determine it. Correct? So we don't know that. Okay? When you go back to your little book, or you go back to your little cards, there's only one rhythm that meets those parameters. It's going to be atrial flutter. It's the only rhythm that has,
Once you said slow, I knew it.
well, regardless of the rate. Because you can have atrial flutter that's very fast.
Yeah, but you can't have AFib like that.
We're not talking about AFib.
No, but she had originally, we were thinking that.
Okay, the difference between it is AFib. Let's talk about fib versus flutter. Again, I have a very simple mind, okay? So when I think of fluttering, think of like a bird's wings, flutter, right? Regular, it's regular. When I think about fib, I think like a bowl of jello. It's kind of does a little wiggle jerk, right? If I look at this, I can see a shape, a definitive shape to it. Unlike fib, it's like a bowl of jello, okay? When you think about V-fib, is there any real structure to it? Or is it just kind of a bunch of jumbly lines? Ventricular, ventricles are fibrillating. The ventricles are like a bowl of jello. In this case, it's the atriums are like a bowl of jello. The ventricles are working perfectly fine. They look normal. So the atriums, which are the P waves, in atrial fib, you're going to have this fibrillation waves, or fib waves. So the QRS is going to look normal. Does that make sense? Like with V-fib, ventricular fib, are you going to have QRS complexes in V-fib?
No.
No, because the ventricles themselves are fibrillating. They're like a bowl of jello. Are you going to have any atrial firing with V-fib? No. So you're not going to have a P wave. So it's important to know. If you didn't understand the difference between fib and flutter, we're making progress. Okay? Now, so whether you're talking about atrial fib, atrial flutter, where you're talking about atrial tach, you have to know the rules. And you have to know these rules. Does yours have the rules on them? No, just have it. Yeah, you can take these pictures and you can mount them onto a 5x7 card or whatever size card they'll fit onto. And on the back of it, you just fill in these 5 answers for each one of these. And every single time, it's going to be that rule, regardless. So if you pick it up and you say, all right, is it fast or slow? Well, the first one, I really don't see any QRS complexes. I don't see any P waves. I don't see any QRS complexes. There's no real regularity to it. It answers those questions. If you come down here and you look at, junctional. Let's do junctional.
No, we don't have to know those ones.
No junctional?
Well, they're good to know.
We really think.
You're going to need them eventually, so you might as well understand them at least.
She's
Okay?
setting us up for failure.
So here's a junctional rhythm. I'm
That's
going to go
why I
back to
don't
my
like it
artwork.
when things
Right.
are taught like to pass a test, right?
Mm-hmm.
Like
So
we're not all
On the same page.
a test.
Right. Great. I'll learn something new every day. She just flew right over there, the PowerPoint.
This one thing, keep going.
I'm going to say heart rate 40. Okay? So, the fast, slow, or normal?
Wow.
Slow. Slow. Okay? Rhythm. Regular or irregular? Regular. Best I can draw it. Okay? Is there a P for every QRS? No. Is there a Q for every P? There's none.
There's no P.
No P's. None. Put down none. Okay. PR interval.
There's a one.
Can't answer that because there's no P waves. So no. Okay. It is the only rhythm that is that answer. It's the only slow rhythm that's regular with no P's.
So the atrium's not working.
Here, let's look at it mechanically, and we'll understand why it looks the way it does. So, if I had to say, where is the electricity starting, right? Where is the pacemaker? If I call it a junctional rhythm. It's not a sinus rhythm, because that comes from the sinus node. Coming from the AV node, the AV junction. So, if I'm not firing the atriums, can I have a P wave? No. So if I fire just down through the ventricle here, I'm going to have just the QRS. That makes sense? Now, what if I do this? What if I fire down the ventricle like this, and I get a T wave because that's the repolarization of the ventricle, right? And then it fires this way.
What?
Now what's it going to look like? Going to do what?
It's gonna go negative.
It's going to go negative. That's right. I can get a retrograde P wave. Okay. Can I do this? Can I fire the ventricle and then fire my atrium? Get it done. If you look at it, it's almost like two P waves. Can that happen? Yes, it can. So you can get any of those things can happen with a junctional rhythm. Most commonly, you'll get a retrograde or none at all. Retrograde P or no P wave at all. Okay? But it's typically 40. Can I have a junctional rhythm with a heart rate of 62? Does it meet the rule? No, not in rate, but it's the only one that has no P waves in front of a regular rhythm. And that's called an accelerated junctional. It's the only one that does. Process of elimination. If you look at your other rhythms that are regular, what other rhythms do you have that's regular? Well, you got a first degree AV block. We got sinus tach, sinus Brady. Can't be atrial flutter because that has more P's than QRS's. Can't be atrial tach. What else is there? Can't be any of my heart blocks because they're irregular. Can't be SVT, it's too fast. What else you got? Nothing. Process of elimination. Good so far?
So, if we can backpedal just a tiny bit,
Backpedal.
aside from like the rate changes, what clinically does someone present with?
What kind of what?
What clinically, like, do they?
Oh.
I've heard of some people know when they're an AFib. They don't know. When
Oh,
they're
so
an AFib.
now we're talking about atrial fib.
Well, no, like with the bundle branch blocks and the junctional rhythms, do they
Okay.
present clinically in any way?
Maybe. Let's do it, chair. I've been standing too much today. Today's my OR day. Oh, interesting. We had a young lady who, I remember this, she went to Corning, back when Corning Hospital was in the old hospital. Got sent there from a soccer game. She had, she had played the majority of the game, and I think, if I remember right, for some reason, I don't remember why, but somebody decided that she needed to take her blood pressure. I think she complained of a headache. Somebody decided to take her blood pressure. And in the process, they recognized that her heart rate was 30 after playing soccer.
Oh my God.
And I thought, whew, something's wrong. So they sent her to the hospital. She had no other complaints. And remember, by the time she got to the hospital, her headache was gone, right? They put on a EKG on her, and she was in third-degree heart block. Well, perfectly fine. So she got sent down to Sarah by ambulance, right? In third-degree heart block. She saw her electrophysiologist, and the electrophysiologist said, that's nice, go home. With a heart rate of 30. Why?
She was asymptomatic.
Correct. So, do they have to present with anything? Some do. Some complain of maybe shortness of breath. Some, depending on what rhythm we're dealing with. If we're dealing with atrial fib, usually when people go into atrial fib, initially the body doesn't like it. It's not normal, so it tends to be faster. So people feel palpitations, they may feel short of breath, they may feel fatigued, they may notice that they've got some edema. We may stumble across it because of something else they came in with. With slow rhythms, it's usually the fatigue. Sometimes we come across it with syncope. I saw a guy that came in to see me just recently as a follow-up to the hospital. He'd actually gone into cardiac arrest. Now, whether it's actually a cardiac arrest, he may or may not be. And unfortunately, when you think about somebody passing out in front of you, what does that do to your level of anxiety? Right? How long are you supposed to check for a pulse for? You guys taking CPR yet? That was a long time ago. 10 seconds for a pulse check, right? 10 seconds feels like a freaking eternity when somebody's not breathing in front of you, right? Or you think somebody's not breathing in front of you, right? Oh my God, there's no pulse! Heart compressions, right? So did he have a pulse, or was it just so slow that nobody gave it time to feel it, right? His heart rate was in the 20s, all right? So you figure that is what, 1 beat every 3 seconds? So, yeah, so that's a heart rate of, 1 every 3 would give you a heart rate of 60. So at 20 beats a minute, 20 beats a minute is 1 beat every 3 seconds. And if you're giving it 10 seconds, that's 3 beats that you're trying to feel in 10 seconds, right? So they did some CPR, they put him on a monitor, they gave him some epi, some atropine, and they still only got heart rates in the 30s or 40s. They intubated the guy, and somebody said, hey, wait a minute, I think I feel a pulse. It's really slow, so they put a temporary pacemaker in him, sent him to ICU. Once they got the temporary pacer into him, his blood pressure came up, he woke up, they could extubate him. So he wound up getting a heart catheterization, and they said, he's got heart disease, but that's not the cause of what the problem was. He needed a pacemaker. So he presented with the utmost of symptoms with a heart rate of 20, passed out. All right, was he truly cardiac arrest? Probably not, but either way, may have been they call it pulseless electrical activity or electromechanical dissociation, where his heart rate was so slow it wasn't generating a blood pressure that they could feel. That's possible. But either way, he wound up with a pacemaker, all right? It varies. The idea is first of all, be able to identify the rhythm that they're in, treat the symptoms for what the symptoms are. If they're short of breath, treat the shortness of breath. If they're in heart failure, give them diuretics. If they need oxygen, give them oxygen. If their blood pressure is low, treat low blood pressure. But you're treating the symptoms. But you got to be able to identify the rhythm in order to figure out, is it something dangerous? Is it something I need to deal with? Or can I deal with it later? Okay. Okay. So, let's move on to heart blocks. Everybody always have problems with heart blocks. So heart blocks. This is kind of a stupid example. If you don't get it, I'm okay with that. But this is the way somebody described it to me once. Have you ever seen these old movies the old war movies where there's a guy standing by the gate, the guard shack is right there, and there's this gate. In order for the truck to get through the gate, he has to go over there and push down on the lever, which opens the gate up, and then the truck drives through. Ever seen that? Sorry. You're probably not going to realize the analogy here, okay? So, if I have this gate, or a door, whatever, I come up to the door, somebody comes out there, opens the door, I walk through the door, right? Come back the next time, I go up to the door, somebody opens the door, I walk through the door. How predictable is that? Very predictable, right? How reliable is the guy at the door? Very reliable, because he opens the door every single time as soon as I come to the door, correct? All right. So now let's pretend that the guy who's opening the door is 500 pounds and has bad knees, right? But they take him a little while, but he's reliable, right? So I walk up to the door, takes him a little while, he comes in, opens the door, and I walk through. I come up to the door, takes him a while, he opens up the door, and I walk through. Okay? Is he reliable? Is he predictable? Yes. Is it normal?
No.
No, because it takes him a while. All right? So in this case, it takes me longer, actually here to here, longer than 200 milliseconds, or 0.2 seconds. That's a first degree block. It's the most reliable, most predictable, but still not normal. Yeah.
So I know obviously you're drawing this free-handed.
Right.
Is there technically a Q on there? Or
It doesn't
no?
have to be.
Okay.
Remember, a Q is just an electrical impulse. It has nothing to do with the rhythm. Okay? And this is what we teach the difference between interpreting a 12-lead EKG versus rate and rhythm. Because people try and think they're the same. They're not. Interpreting a 12-lead is interested in the shape. The shape of the Q, the shape of the R, the shape of the S. With rhythm interpretation, they're not. They're all about timing, right? So in this case, all we're interested in is it's nice and regular, it's nice and predictable,
Right.
it's just not quite normal,
Okay.
all right? We're good with that, all right? So now, let's move on. So now let's say I come up to the door, stop the door opens right up, walk through. Next time I come up to it, takes a little bit longer for the guy to come over, opens up the door, opens up, and walk through. Next time I come up, takes him even longer. Opens up the door, and I walk through. Next time I come up to the door, he doesn't open the door. I leave. Right? Sergeant comes over, finds out the guy slept through me coming up there, kicks him once right in the ass. He's like, oh, okay, I'm back to work. Right. Comes up. Next time I come up, he comes up, opens up the door real quick. Next time I come up, takes him a little bit longer. Next time a little bit longer. Next time I show up, he doesn't open the door, and I drive away. Okay? Is he reliable?
No.
Is he predictable?
So.
Well, let's draw it out. Okay?
It's got a
So here
pattern.
I am, drive up, opens the door, and I drive through. Drive up, takes him a little bit longer, opens the door, I drive through. Next time, takes him even longer, opens the door up, I drive through. Next time I show up, he doesn't open the door. Next time, I drive up, he opens the door right up, I drive through. And this recurs every single time.
So then it would be predictable because you know after so many times that, no, that's me saying it.
Correct. So is he reliable? No. Because there are times when he doesn't open the door. However, is he predictable? Yes, because there's a pattern. Okay? So if we go back to this, let's say the heart rate is, we'll make it 50. Okay? Rate, fast, slow, or normal? Slow. Blocks typically are slower. First degree, not necessarily. Can be a normal rate. But generally, your second and third degree blocks are typically slower. So it's slow. Rhythm. Is it regular or irregular?
Irregular.
Ah. Okay, irregular. But under irregular, is it regularly irregular or irregularly irregular? It's regularly irregular because there's a pattern to it. Okay, that's the difference between the two. Is there a P for every QRS? No. Is there a QRS for every P?
No.
No, there is not. Okay? So if you go back and you look at this, there's only one rhythm that it can be. Is this rhythm? Because of what you answered. Okay?
What's the
So,
second degree?
This is, so we went from first degree, now we're in second degrees, we have type 1 and type 2. As you progress through, they become more unreliable and more unpredictable. So you have first degree, then you have second degree type 1. So this is commonly referred to as a winky bot. Or secondary type 1.
Oh,
Winky.
okay.
Think about, what'd she call it?
That's what she called.
Pointed
Yeah. I was like, what the hell is she talking about?
So,
That's the random QRL?
so a winky bot is, they typically say longer, longer, longer drop. Longer, longer, longer drop. But it doesn't matter the pattern. It can be every third, every fourth, every sixth. But you're looking for that drop.
So where
line.
that random Q wave is, that's the winky bot?
You know, what it is winky bot is the pattern of the PR interval. Longer, longer, longer drop. Repeatable pattern. Longer, 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 longer drop. It's a repeatable pattern, regardless of how many times it takes you to get there. But the big key is your PR interval is not constant.
Okay.
It's constantly changing. Because if I put a set of calipers on here, it's not going to be the same, right? It's going to change. Now, the PR interval after the drop will be the same as the starting PR interval. And it's just going to keep repeating itself. You just have to find the pattern, okay? Now, that's a second degree type 1. Unlike a second degree type 2, again, remember I said it's repeatability and predictability. The more unpredictable and unreliable it is, the worse the rhythm is. Right now, as I said, is this predictable?
Yeah.
Yes. Is it reliable?
No.
No. Okay. Now, let's say I come up to the door. Come up to the door, opens right up. Come to the door, opens right up. Comes to the door, opens right up. Comes to the door, closed. Okay. Come to the door, opens right up. Come to the door, opens right up. Come to the door, closed. Draw that out.
These things piss me off drawing. I'm not artistic.
Okay. So, came to the door, open right up, drove through. Came to the door, right, opened it up, drove through. Came to the door, closed. Came to the door, opened right up. Came to the door, closed. Came to the door, closed. Came to the door, opened up. Oops. Drove through. Came to the door, opened up, drove through. Came to the door, opened up, drove through. Came to the door, closed. Is it reliable? No. Is it predictable?
No.
No. No and no. Okay? This is worse than this is. Okay? When he does open the door, he opens it quick. But I can't tell when it's going to happen. Does that make sense? All right? So he's semi-reliable in that when I drive up and he opens the door, it's quick, but I don't know when he's going to open it. So it's kind of semi-reliable as opposed to, I'm going to come up to the door, it's closed. I drive away, he opens the door. I come to the door, it's closed. I drive away, I get a mile down the road, he opens the door. So I have no idea when he's going to open it, and he has no idea when I'm going to get there. So, third degree block, let me ask you this. Is it pretty easy to identify this?
So that is, if it's not reliable but predictable, it's a second degree
Type 1.
type 1.
Okay?
Okay.
It's got a repeatable pattern. It's
Okay.
predictable. I know this rhythm. I can see this rhythm. It stands out. Okay?
Mhm.
Now, one of the things that I kind of learned right off is it gets sometimes a little bit foggy trying to find this one because except for these dropped QRSs here, it looks normal. It looks like a normal rhythm because it is. It's just trying to find these extra P waves sometimes gets a little bit hard to find them, and then trying to figure out what it's doing. Unlike third degree block. Here's the key to third degree block, okay? So I'm gonna draw this.
So second degree, type 2 is not reliable or predictable.
More predictable, right? But so is a third degree block,
Okay,
all right? The big key on this one is the PR interval is normal,
okay.
all right? With this one, you're gonna identify this one in a heartbeat in a second. All right. Okay. Now, the key to third degree block and the way that you can differentiate this from any other heart block, you know it's going to be slow, right? Because we said blocks are slow. Third degree block, if you look at the PR interval, the PR interval is never the same. It's always changing, okay? But if you look at the R to R is always the same. And if you look at the P to P is always the same. There's just no correlation between the P and the QRS, unlike there is here. So if you can identify first degree, and you can identify second degree type 1, and you can identify third degree block, this one, you're just looking for a normal rhythm that just drops QRS complexes. Other than that, it's perfectly normal.
Okay, so the third degree, there's no correlation between, what did you say?
There's no correlation in the PR. The PR interval is never constant.
Okay,
It's always changing. But P to P is constant and R to R is, the distance between P to P is always the same, and the distance between R to R is always the same.
okay.
Why is that? Let's draw that out, and you'll understand why. What's that? Go ahead.
It's like trying to match your turn signal with somebody else's.
I know.
Your turn signal is always the same, and theirs is always the same, but like, they're never gonna
What's that?
match up correctly.
Oh, you're talking about,
Like if we both turn on our turn signal at the same time,
oh.
or tried to.
What? We're still on turn signal.
What side of the steering wheel is it on?
I
know, we're not going there.
This is how I think about stuff, though.
Hey, whatever works. I am, wait till we get to heart failure. You'll see. What? Really? You think of the heart that way?
There's more.
So, this is third degree block. They call third degree block complete heart block, right? Why? Because the AV conduction here is completely blocked. All right? So when the SA node fires, what's that making? What wave?
P.
P wave, okay? What's the intrinsic heart rate of the SA node?
60 to 100.
Okay? So normally we'll say it's 60 to 80 beats a minute. So your P wave is gonna fire at 60 to 80 beats a minute. So if you were to actually map out this rate of just the P waves, it's gonna be 60 to 80 beats a minute, probably more towards the 60 range, okay? Now, that electricity is not getting through to the bottom chamber, but the heart still has to beat, right? So it has a backup pacemaker. Well, it can't fire at the AV junction because the AV junction's gone. So its backup pacemaker is down here in the LV, okay? The intrinsic heart rate of the ventricular backup pacemaker is what? Okay, well, if you don't know that, that's important to know. It's 20 to 40.
Intrinsic heart rate of the left.
So this is 40 to 60,
So I think it is 60.
and this is 60 to 80. So your SA node's 60 to 80, AV node's 40 to 60, and your ventricular, your Purkinje fibers, that area is 20 to 40.
Okay,
So if you were to look at the QRS complex firing, now your QRS complex is gonna fire at 20 beats a minute. Okay, that's why your R to R is regular because this one's firing on its own, and your P to P is regular because it's firing on its own. The two of them just have no idea the other one exists. That's why there's no correlation between your PR intervals, because they're not talking to each other.
Because there's a block there.
Because there's something has knocked out that conduction system through the heart. Mhm. Does that help?
Mm-hmm.
Does that make you more confused?
I don't even know at this point.
Works in my head, so I'm good.
I don't even understand
come to
where
me
my
later.
signal is, so I can't even.
I know I got a steep hill to climb with you. I just get that. Yeah, as long as you know where the brake pedal is.
I do know where that is.
Okay, that's good. And you lead for
My
home
car
running?
kind of drives itself.
It does?
Yeah,
No, it really
I have
does.
a new car, so it,
Autonomous vehicle.
yeah.
She just has to touch the steering wheel every so many seconds and the car just
Every
goes.
like minute or so I have to, it'll ask me to put my hand on the steering wheel. But other than that, it really just, it does its own thing, so.
She tried it out, well, she showed us on a train one day.
And it just turned itself.
Yeah.
So, how are we doing? Are we doing at least maybe have a better understanding of this
Yes.
and heart blocks?
Yeah.
Okay. Do you want to spend any more time on rhythms? Now you just need to go back and you gotta say, all right, I need to take the time and I need to focus on my 5 steps and focus on your normal rhythms. Don't pick up the weird stuff, all right? You know, your sinus rhythm, your sinus tach, sinus brady, AFib, aflutter, junctional, your VTach, VFib, asystole.
Asystole is pretty.
Yeah.
You're right on the money.
Well, I'll tell you what, I've seen some AFibs that look really regular, okay? But unless you've got a set of calipers and you're actually measuring it out, then you can see the irregularity, but the key is look for the flutter waves, all right? If you can't see something that you can say, that's a P wave, if you have to make an argument and say, well, that one might be, I kind of think that one is, it's not. If you have to argue to yourself if it exists or not, it's not there. And if it's not there, it's not a P wave. It's not coming from the sinus node. It's not a sinus rhythm. Okay? Now, one of the things that I've done is sometimes, depending on what lead I'm looking at, I have to jack up the we'll call it the magnification. I have to enlarge the impulses in order to make the P wave visible.
Mm-hmm.
All right? But even if you do that and you say, I can't see anything in there that looks like a P wave consistently, it's not there. Okay? Good. Next topic?
So what would you,
What would I call that? Bunch of squiggly lines.
that's what ICU said.
I would tell you that,
So that was pulses back.
I would tell you that there's really not a whole bunch to go off from. So you know how we were talking about identifying somebody's heart rate?
Mm-hmm.
Okay, let's take this for example, all right? So this is 1, 2, 3, 4, 5 beats. 5 beats in a matter of, less than 5 seconds, I think. So if I had to look at this and I wanted to guess what their heart rate is,
Mm-hmm.
okay? Was it you that was asking the question about the boxes? Who was asking me about it?
No, aren't you?
Well, the 300.
The 300,
Yeah.
okay. So if I was to take this, and I found a QRS complex, this one's pretty close to online, right? So 300,
I feel like I'm learning better about this
150,
than I have in a
75.
lecture.
So it's a little less than 75 beats a minute, just by taking 2 beats,
Oh,
okay? So everybody's, I'll tell you, I can't do this very well. Does everybody else not understand how to take the boxes and tell what somebody's heart rate is? I can walk around and show you. This one's,
I don't.
Don't?
I'm being
Okay.
honest. Like,
no, that's all right.
I
This is-
noticed that you cut them in half, but like that was.
It's easier than that. So I find a QRS that lands per line, okay? So we're gonna say that one's pretty close to a line. So if I go over one box, there's 300, there's 150, there's 75, and since it's over here, it's a little bit less than 75 beats a minute, just by looking at 2 beats.
For a second.
Make sense? Understand that? Okay. Anybody else? You know, if I had to look at that, the first thing I'd say is, does it have a pulse?
So that was, what, our 6th or 7th time of getting her back?
Yeah.
That we worked very
Well,
well.
getting her back, did she have a pulse and a blood pressure? Or just a rhythm?
That was a nasty thing that we ran out.
Yeah. So, is this your pen?
That was mine.
That was yours. I'm a pen thief, by the
And
way.
your
And, oh, you're right.
Sorry.
We almost had a mess. All right. So let's move on from rate and rhythm interpretation. Let's talk about heart value and drugs. Pharmaceuticals. And by the way, if you feel like getting up to get something to eat, get something to eat.
Yeah.
Don't let me stop you. All right. How many of you in here have some idea of how an engine works?
I know I.
Do you know that an engine has to have fuel? It has
Cylinders.
to have air, right? It has to have spark,
Story of my life.
right? It has to have valves in it, right? Am I good with that? All right. I'm surprised how many people don't understand how engines work, but that's the problem with being mechanically inclined and somebody who's not trying to teach heart better. All right. So, I'm also, by the way, I spent a good number of years as a paramedic firefighter. So, one of our things is to move water. What we do, right? Move water from point A to point Z and put the wet stuff on the red stuff, right? That's what we do. Now, if you look at the heart, all the heart is a series of hoses and pumps. And they're gas-powered water pumps. So here's my heart value diagram. This is my heart diagram. So we are going to make a pump here, and we're going to put a pond and a pond. And we're going to put hoses with one-way valves. Okay? In this scenario, what's going to happen? Okay? This pump is going to suck water out of here, drop it into that pond. This pump is going to suck water out of that pond and drop it in that one. Everything's going to be happy, right? So what's going to happen to the water level in these two ponds if everything is working normally?
Should be equal.
It's going to be the same. It's never going to change, right? Well, guess what? In upstate New York, it tends to rain, doesn't it? Oh. There's rain. This pond has a roof over it. Now what's going to happen?
Be uneven.
You're going to have some flooding, aren't you? So what do we have to have? We have to have a drain, right? We have a drain. Okay? Now, inside the pumps are valves. Oh. Give me 1 second. Yes, sir.
I'm literally not kidding in the fact that I'm literally,
Okay.
this makes more sense than the way that Jess has been explaining that.
Yeah, why don't you do that? When you said he's coming in for a cath tomorrow?
Hello.
That diagram of the heart interval.
I don't know.
Unlikely. All right, yep, down my way. All right, thank you, sir. Bye.
I can't remember.
Okie doke. So, oh, we lost somebody. You can take a break. Take a pee break. Take a break. Oh, okay. So in this scenario, ponds are happy again, correct? Now, whenever you see flooding, you have to ask yourself, why did the system break down? What happened, right? So take, for example, let's say that this pond is flooding. So something from here caused a problem to here. Does that make sense?
It backed up.
Backs up, right. If this pond is overflowed, anything from here backwards can be the problem, correct? So when you see flooding, you have to ask yourself, where did the system fail? Okay? So let's take this pond, for example. We're going to start labeling some structures, okay? This is your left ventricle. This is your right ventricle. What do you think this is? Even simpler. This is your body.
Oh.
What do you think that is?
I think it should be a bigger pond.
A bigger pond with a lot of fish in it. Goldfish. So what do you think this is?
Lung.
Lungs. Very good.
Wow.
Lungs. Okay. So now let's take somebody who's got fluid in their lungs. Can that be caused by a problem here? Can it? So if this backs up here, where's it going to go to? The body, right? Can it go any further than that? There's the drain, right? So you can't have something here causing a problem there. It has to be from here backwards, okay? Because this is the end of your circuit, the drain. So if we can make the drain, it's going to overfill and fall at the drain. What's the drain called? Talking about the body now.
Urine.
Kidneys. Kidneys. So think about somebody who has who needs dialysis. Are they going to be? Is their pond going to be overfilled?
Yes.
Yes. All right. Now, people typically deal with chronic but slow backups very easily, and it can back up in the body very easily. It's the quick, acute stuff that the body can't deal with very well. So let's think about here. Valves. We got two valves on the left side of the heart. What are they?
Tricuspid.
Quiet off back there.
They always are.
Pulmonary. Pulmonic.
No. Left
Mitral.
side. Left side.
Toilet paper mask.
Aortic. Aortic.
Right, I was trying to think of the thing.
So aortic and
TPMA, yeah.
It's toilet paper my ass.
Bicuspid.
okay. So in which case, if that's aortic, what's that?
Mitral.
Mitral. Fine. Mitral.
That's a new
I
one.
told you, I'll teach you my tricks.
I learned that in elementary school.
I will never forget that.
With
All right. So anyways, let's say somebody's got aortic stenosis. They have a rusted up valve. Will that cause things to back up? Yes. Aortic insufficiency or aortic regurgitation cause things to back up. Mitral stenosis, mitral regurgitation can cause it to back up. What if their left ventricle is weak? That can cause things to back up. So what's this? This is hoses, right? These are all hoses. What are these hoses? These are arteries. These are arteries, okay? So this would be the, coming out of the lungs, this would be actually called the pulmonary vein. But it's
Yeah,
still an
because the
artery.
vein is the only one that carries
Those
for
are
the lungs.
That's where I get.
They get screwy,
Yeah.
right? It's actually the pulmonary vein. This would be the pulmonary, well,
The
actually,
lungs are the only things that are opposite.
correct. Because it's actually, arteries are away from the heart. So if blood is leaving this side, it's going away from the heart,
And
okay?
with oxygen, yeah.
And veins are going towards the heart. That's why this is the pulmonary vein, this is the pulmonary artery, okay? But these are arteries. And these are veins. Okay? So we're not gonna worry about the pulmonary artery and the pulmonary vein. We're gonna say arteries and veins. If somebody suddenly acutely jacks up their blood pressure, that's like a kink in a hose. It's resistance to forward flow. Okay? That can cause things to back up. So when you see fluid here, you have to say, what happened here? When you see fluid here, you have to say, what happened here? All right, let's look at these veins, these valves. What do we got over here?
Tricuspid and
Yep.
Toilet paper, mine. I won't forget that.
We learned that in paramedic.
That's actually like
What's that?
We learned that from paramedic years ago.
Wow, never learned that one. I learned all kinds of neat stuff. All right, so let's talk about a bunch of different scenarios. Somebody has venous insufficiency. Somebody who's a let's make it even easier. Let's say the person who has had 6 kids and stands on their feet at the checkout counter at Walmart all day.
They should wear TEDs.
What's that?
They should wear TED holes.
Why? Because the veins get all stretched out, right? When the veins get all stretched out, what are in veins that are not in arteries? Valves, right? When the veins get all stretched out, how well do the valves work?
Not good.
They don't, so everything pools down there and they get what? Varicose veins, right? Is that swelling in their legs? Yes. Is that caused by a heart problem?
No,
No.
per se.
It's caused by bad hoses, right? But guess what? It's still called congestive heart failure.
Really?
Congestive heart failure is anytime you see fluid backup, regardless of the cause. When you have
So fluid backup in the body is always due to the right ventricle, and fluid backup in the lungs is always from the left?
Nope.
No,
Nope.
okay.
So that's what I was saying. The body can deal with chronic issues and absorb it in the body very easily. Like if somebody has chronic aortic stenosis or chronic mitral regurgitation or chronically low EF, their body will put up with those chronic conditions, and that backup will be translated through this system all the way back to the body, because it's sort of like a pop-off valve of the body, all right? It's the acute changes that the body doesn't deal with and you wind up in the lungs. So you have somebody who has, in my world, I run a valve program here. I replace a lot of aortic valves, okay? So I see a ton of aortic valves, ton of mitral valves, and which I was having this discussion with this lady on the phone today. Her valve is about 1/4 the size opening that's supposed to be. Her body's compensated for it, as long as things are remaining stable. If she suddenly gets sick, what's gonna happen to the workload on the heart?
It's gonna increase.
It's gonna increase. So now it's gonna start pumping harder, more aggressively, more volume out through a tight hole.
So does that have to do, sorry if I'm going off, does that have to do with your stroke volume and your,
Oh, now you're
because
talking.
I don't understand, like, I was reading about it also. I've been trying to read because I don't understand the heart at all. And I didn't understand, like, stroke volume and, like, how your stroke volume and your heart rate and your, the workload and your output increase, but if your heart rate goes over 160, then your stroke volume decreases and your cardiac output
So
decreases.
we'll get into that in a minute.
Okay.
Let's understand the basic concepts of this. And
Okay.
then we're gonna talk about Starling's curve, which is what you're talking about.
Okay.
Right? So now, as long as the system is stable and compensated, things can translate back through, because the right ventricle's a very flexible organ. It's a very thin-walled structure. It can absorb pressures, all right? But the valves get pulled apart and they leak. So if something is chronically backing up, this side will absorb it, and you'll see it down here in the bottom. That's why people have dialysis. Do they always go to dialysis every other day routinely without fail?
No.
No, occasionally they skip a few days, right? Do they just drop over dead from pulmonary edema? No, their body absorbs it because it's a chronic, slow disease, as long as somebody doesn't tax it. So you have somebody who has aortic stenosis and then spikes their blood pressure. They kink this hose on top of a tight valve. Their body may not be able to compensate, and it backs up. It's going to back up right into the lungs, okay? Somebody throws a pulmonary embolus, right? Pulmonary embolus from the body. Where does it go? It goes through the veins, goes in the right side of the heart, leaves, and gets stuck in a vein in the lungs. So what's forward flow like from the vein? Is it good, or has it got a blockage on it? It's got a blockage, so it's going to back up, right? Depending on how big a clot it is, right? It's going to back up. So it's going to back up into the right side of the heart. Right side of the heart is very flexible, right? Can't take the pressure, and it gets expanded, right? What's it do to the tricuspid valve? Pulls it apart. Now the tricuspid valve leaks. Then where does it back up to? Backs up into the body, and you get edema. Can you get congestive heart failure, pulmonary edema from a blood clot in the lungs? It's gonna back up here.
No,
No,
no.
no, because it's in the venous system,
Oh, okay, I see.
okay? It backs up. Can you get shortness of breath? Sure you can, but not from pulmonary edema.
Okay.
Because it's not a backup of fluid into the lungs. Does that make sense? You sound like you're still questioning it. Move on, continue with some other things, all right? So when you're examining a patient, when you're treating a patient on the floor, left side heart failure, right side heart failure, why ventricular failure? You can have one, other, or both. But you have to say, where did the system break down? All right, let's take a few other things. What makes a car run? We talked about this, right? Number one, what do you need to make your car run? Unless it's electric, you need gas. You have to have fuel. Okay, what else do you need?
Combustion, air.
Oh, okay, let's go with, you have to spark, right? So spark. What else do you need?
Oxygen.
You need air, yep, air. What else do you need? What's that? Yeah, well, you have to have valves, because there are valves in there, and that helps with compression, so you have to have valves. Right? You have to have a way to get the fuel to the engine, right? So you have to have intact fuel lines. Okay. You have to have exhaust, right? You ever see, there was a few different comedy shows where people will take, I think it was Beverly Hills Cop. He took a potato, he jammed it in the exhaust pipe, right? And the car stalled because it can't exhaust, right? So you have to have an intact exhaust. So when you have a system that's failing, you have to go through this checklist. So what's fuel? Blood. So if somebody's anemic, are they going to have problems with their pump? Yeah. Are they going to have problems with their blood pressure? If their volume's low? Yep. Okay. Spark, that's their electrical system, right? That's their heart rhythm. All right. So if somebody's in a rapid atrial fib and they've got a heart or a pump that's functioning only at 10%, and they suddenly go into atrial fib, are they going to back up? They got a weak pump that's not pumping normally. Can back up. Air, lungs, right? Get these people with their emphysema, their pulmonary hypertension. So, say somebody's a smoker, right? Pulmonary hypertension. Anytime you see the word hypertension, think of a kink in a hose. So here's the pulmonary system, right? They have a kink in the hose here. What's going to happen? It's going to back up into the right ventricle. You're going to see the right ventricle being dilated. It's going to pull your tricuspid valve apart. It's going to increase the size of your atrium. It's going to back up into their body. Okay? So you have to have intact lungs. Not to mention, if somebody is hypoxic because they've got emphysema or a bad COPD, are they going to get oxygen onto their hemoglobin? And you're going to suffocate the heart for oxygen. Is it going to run real well? Nope. Okay. So you have to have intact valves. We already talked about that. Fuel lines. You have to have intact fuel lines. Whether it's arteries or veins, they have to be working properly. We already talked about varicose veins, right? And if somebody's got a hole in an artery, like from an aortic dissection, are they going to run very well? No. Exhaust. They have to have intact kidneys. So when something is failing, you got to go on these things. So let's talk about medicines that we use. So this will go back to your question about Starling's curve, okay? Mm-hmm. So if I have a faucet that's flowing water out of it at a certain rate, okay? And I have a bucket, okay? And over here, I have a tub, and I'm trying to fill the tub. I'm going to take that bucket, right? My bucket's getting full, right? Well, now I'm like, God, I gotta get over there quicker. So now I only allow it to get 3/4 full. 3/4 full, right?
Mhm.
I'm still increasing the volume in my tub, right?
Right.
Now I come over here, bang, drip, drip. How fast am I filling the tub now?
Slowly.
Right. So I don't give enough time for my bucket to fill because my rate's going too fast.
Okay.
All right. So initially, we do this in the fire department. The guy's at the end of the hose and he says, "I need more pressure." I can turn up the RPMs and I can increase the volume that I'm sending because my pump is getting almost completely filled with every bucket. But once I get beyond a certain point, my volume at the end of the hose is going to drop because my RPMs are going too fast and now my bucket don't get filled. That's Starling's curve. As you increase heart rate, volume increases to a point and then your output drops. That's Starling's curve.
What is ejection fraction?
Okay? So what's the definition of fraction?
Part of it?
Part over the whole, right?
Is heart rate.
So you have part
output drops.
over whole. So, I'll make sure I didn't write forward. Spelling's not my attribute, what did I say? All right. So what I do is I use an ultrasound and I look to see how full is my heart when it's relaxed. And then I look to see how much is squished out with every beat. So the whole is the volume at rest. So what phase is the heart at rest?
Repolarization.
So think about blood pressure. So what phase is the heart when it's resting? Diastole. So we look at the heart when it's rested in diastole, and we look at how much volume is left in systole. And that is your ejection, how much is ejected out when the heart squeezes.
So is it like your blood pressure? Your ejection fraction is your blood pressure?
No.
No,
So,
it's those divided.
Yeah.
Oh, divided.
correct. So let's put some numbers here.
Okay.
Let's say in diastole, my heart will fill with 200 cc's. And let's say it squeezes out and I'm left with 100 cc's. So my ejection fraction is 50%.
And we want over 60, right?
So it's supposed to, normal is between 50 and 65%. Now you have some people that have hyperdynamic ventricles, well, they'll be up to 75, 80, 90%. But usually when somebody's hyperdynamic, you think about a heart that's super squeezing, right? What kind of medical conditions would make your heart super squeeze? Think about somebody's hyperthyroid, right? Think about somebody who's got an infection. The heart's super squeezing because it's trying to keep up with the demand of the body.
And wouldn't it get fatigued?
It does. It does. That's why hyperdynamic, you want to try, why is it doing this? All right? So what do? We try and fix that problem. Just like with this system here, okay? We try and fix the problem. Now, going back to your thing, what happens if heart rate gets too fast? Stroke volume goes down,
Right.
right? So do we want a fast heart rate?
I don't even know what stroke volume actually means.
Well, what's the volume per stroke? So think about, all right, so I'm shoveling, that's a stroke. I'm paddling, stroke, right? How much can I move with one paddle? How much can I move with one shovel? How much can I
So
move with one
What do you
pump?
mean, like, move?
Move, blood,
How much
Blood.
blood can you move? Okay.
right? How much volume can I move with one stroke,
Okay.
all right? So if I have a heart, oh, you'll love this. So here's a heart like that. Okay. So stroke volume is all of that volume that's in there compared with how much volume is left there. The difference between the two is the stroke volume. It's how much was ejected out. Okay? Ejection fraction is a percentage. Stroke volume is cc's.
So when your heart rate increases to a certain amount, your stroke volume increases. So the amount of blood moving when your heart rate increases makes your the amount of blood moving increase, which makes your heart pump faster, obviously.
So now
because
let's
it's your
add-
cardiac output,
Let's
right?
add some numbers to things, okay? Let's say, because remember, I said that as I'm moving faster, the volume in my bucket isn't as much, but I'm moving more often, okay?
But that's after you get to 160, right?
After I get to a certain point.
Yeah.
And then it doesn't fill enough to match my rate,
Right.
okay? So let's put some numbers here.
Okay.
Let's say that a single pump, single heartbeat moves 100 cc's. Okay? And I do that at 60 beats a minute. Okay? How much volume am I going to move in 1 minute?
100 cc's, 600.
6,000.
6,000.
Yeah, sorry, there's another zero there.
Right, there's another zero. So I'm going to move 6,000 cc's.
I need
Okay.
a calculator always.
I
Sorry.
understand that. I get that. So do I.
I can spell.
Okay?
So I
So
can't do math.
let's do this. Let's reduce our volume. Okay? So is my pump moving less volume per beat?
Yeah.
Yes.
No.
Now let's increase my heart rate. How much volume have I moved?
7,500.
Has my cardiac output
Great.
increased?
Yes. Yes.
Yes, it has. Okay? It'll do that to a point. Because remember, what if I drop this all the way down to 10 cc's and I have a heart rate of 150 beats a minute?
It'll only be 1,500.
Correct. Because I don't have time for my heart to fill because it's beating too fast.
Right.
So we don't like fast heart rates, do we? So what do we give for medications to slow the heartbeat down?
Beta blocker.
Yes. So how do we identify that class of medicines?
Oh, wow.
Oh,
Oh, wow.
Oh, well. I'm not gonna go sing. So anyways, so beta blockers. What other effects do beta blockers have? Why?
To affect your heart, now, slow down.
Oh, yeah, we already talked about rate. We know it affects rates, but is that the only thing it affects?
It affects your cardiac output.
By affecting rate,
What about your stroke volume? I'm just guessing.
okay?
No.
All right, so beta blockers, in addition to affecting heart rate, are also vasodilators.
We knew that.
Okay, knew that.
Yeah.
Because remember, alpha constricts, beta dilates, all right? So now I'm gonna slow the heart rate down, okay? So it gets more chance to fill. But if I wanna pump more volume, would you rather pump the volume through a hose this big or a hose this big?
That big.
Exactly, because that's decreased resistance on the heart. Because if you think about it, let's say this heart was weak. Let's say its ejection fraction is only 20%. You want to do anything that you can to make it as easy on this heart for it to get forward flow,
Right.
right? So if I kink this hose, what's that going to do to cardiac output?
It's gonna make
It's going to be a barrier.
it's
gonna
gonna
back
make it
it up.
harder for them. Yeah.
Right, so I don't want resistance. So beta blockers decrease resistance and slow rate to allow you time to fill.
So if you had like almost like a blockage, like something sorry, I'm trying
Remember, these are systemic arteries. We're not talking about coronary arteries.
to
We're
Okay.
talking about in the body,
Okay.
all right?
So a beta blocker wouldn't work if you had say like high cholesterol where it starts to like block your
I'm not gonna say it wouldn't, but again, if I had a car that was 100 years old, right? And I can't replace the fuel filter on it.
right?
What are the chances that fuel filter is perfectly clean?
Slim to
Probably
none.
slim to none, right?
Right.
What's gonna happen if I start hammering on the accelerator? Eventually it's gonna run out of gas, right?
Right.
So I wanna take it easy on the throttle or on the RPMs,
Mm-hmm.
right? So if I give something to that engine where I can't get my RPMs over a certain amount, my car is not gonna stall out,
Right.
right? So if I have somebody who has blockages and I give them a medication that doesn't allow their heart rate to go up, those blockages aren't gonna be as big of a deal.
So this, even though you have a block somewhere else, this is gonna help decrease the
Can.
workload on your heart so that that's not gonna be as big of an issue. Right?
Correct.
Okay.
But when you're talking about heart failure management, beta blockers are one of the key drugs to allow time for the heart to fill and to squeeze. Now, if you think about these valve issues in here, let's take my old time standby favorite, the aortic stenosis. That's a rusted up valve, right? Doesn't like to open, okay? So, here's a door. If I yell fire, how fast are you gonna get out this door?
At this
Pretty
point,
quick,
I don't
right?
even care.
Now how
Like,
quick
just
are you
let me
gonna get out?
die.
I'd go that one.
I understand that. That's a backup into the other fire,
Yeah.
right? This is your only way out, right? If I gave you more time, you'd get out. But if I push it too hard, everything's gonna back up. So, if I have a narrowed up valve here, I wanna give you more time to get out. So a slower heart rate is better for somebody who has aortic stenosis as well. In addition to the dilation, which decreases the resistance to forward flow. That makes sense. Okay? Now, let's talk about this. How many of you took biology?
Yeah.
Y'all did, right? When I took biology, pardon me, I'm gonna digress a little bit here, all right? In one of my former lives, first out of high school, believe it or not, I actually went to school for accounting and business administration, and I worked as an internal auditor for a bank.
Oh.
That sounds really
I know,
exciting.
that's ugly, it was really bad. It was bad. But anyways, when I first went to college, we all had to take basic stuff, didn't we? That included general biology, right? Well, I'm a math guy.
You just told me you needed a calculator.
What's that?
Were you just being nice?
I'm just being nice.
Oh, thanks.
I love math. I love math. So, anyways, they were talking about this thing called the renin-angiotensin system. And I'm like, who the frick cares, right? It's biology, big frickin' deal, right? Worked in the bank, left the bank, went to working on the ambulance, worked as a paramedic, and guess what? The renin-angiotensin system came back. I said, who the frick cares, right? Right? Got out of paramedic school, worked as a paramedic, went back to PA school, and guess what came back again? The renin-angiotensin system. I said, who the frick cares? Then I started working in cardiology. I'm like, oh, that's why we need to know this. So if you don't know what the renin-angiotensin system is, let me tell you why it makes a difference for you.
I feel like we went over this, right? Yeah.
You did?
Really? It's like
Yeah.
a fluid balancer.
So, what in a person who has a weak pump and has poor forward flow, what's the blood supply to the kidneys like? Low, right? Now, the kidneys have only one way to protect themselves from decreased flow. Because we know that the kidneys are one of the first organs that show signs of shock, correct? All right, so, ready? This is super exciting. So here's the kidneys. Here's the artery feeding the kidney. Here. We already said decrease blood flow. Decrease best friend, right? The kidneys say, I don't like this. The only way that it can get more flow is to increase blood pressure, make the container smaller. So what's it do? What's that? This is the renin-angiotensin system. So what does the kidneys do?
Increases your blood pressure.
How?
Because they send out a hormone.
Which one?
88.
Is it ADH?
No.
No.
It's aldosterone, isn't
Well,
it?
so,
No.
No, it's
if,
Renin.
Oh,
That's why it's called renin angiotensin. Alright, so it releases renin.
Like going over all these.
Right on the money, guys.
Oh my god, I knew it was in there, it's just a matter of dragging it out. It's like, I get it.
so
Alright?
renin renal.
So renin.
There's so much information out here.
So renin binds with what?
Angiotensin 1.
Not yet.
Okay.
Precursor to angiotensin 1. But you're close in the word, it's just not quite right. It's not angiotensin 1, it's angiotensinogen.
Oh,
Right?
Man, I tried.
You did.
Angiotensinogen binds with renin and makes angiotensin 1.
Alright, let me draw this kid.
Okay? Angiotensin 1 gets reacted on by another compound from where? This is really cool.
Okay,
Mother
can you
Nature
say that
knows
one
it
more
is.
time?
Okay, angiotensin 1 is acted on by another compound from where?
From the pituitary?
The brain.
What's that?
That's
Comes
the
from the
brain.
lungs.
Oh.
I know
I'm
why
in the wrong
the lungs,
part of the
but
body right
what's
now.
the name of the compound that comes from the lungs? Nope. Nope. Is angiotensin converting enzyme.
Oh, ACE inhibitor.
ACE, right?
Oh.
That binds and
I feel
creates
so
what?
stupid today.
Angiotensin 2.
Angiotensin 2, which is a potent vasoconstrictor, which increases blood pressure,
Okay.
right?
Yeah.
So now you hit on it. What do we use? We use an ACE inhibitor, which inhibits the release of ACE, which breaks down this process, which causes vasodilation, which we don't want vasoconstriction, right? We want vasodilation.
But what about our kidneys that want
Hang
more
on.
blood?
Hang on, we're getting there. We're
Okay.
getting there, right?
Okay.
So we're getting there. So now I'm not quite done with this. So what's the number one reason why people stop an ACE inhibitor?
Because it makes you cough.
Why? Because it's not allowing it to be released from the lungs.
Yes.
It makes a cough. So what do we do?
We tell them to take Tesla pearls.
No, we don't. We send them to you, and they get mad at you because their cough doesn't get better. No, we give them an angiotensin receptor blocker, so it allows it to come from the lungs, but it can't bind. It blocks it here. So now they don't get a cough. So our
what's that
ACEs,
medication name? What are the blocker names?
well, we're getting there. An ACE ends with what?
Krill.
Prill.
Like Verant. Never
My
mind.
poor Aunt Pearl, right? Or Tessalon pearls for the cough, right? So it's a prill.
It's April.
April, Sinopryl. Oh, yeah, you're right.
ACE. What? No.
No,
You're
ACE.
right. Right, you're correct. But
It is April. It ends with prill.
But the
Because
ACE
Captopril,
inhibitor-
lisinopril, it's an ACE inhibitor.
Right, but I think April.
April, I think you're correct. It is April. I always call it prills, but I think you're right. It is an April.
So this is really interesting to me.
Hang on, we're getting there. So you asked
I
about
love cardiology.
So you asked about the angiotensin receptor blockers, right?
Yes.
Called ARBs, right?
Arms.
ARBs.
Okay, I've heard of that, but I
RB.
There's sartans.
Oh,
Like losartan.
Valsartan, losartan, yup,
That's Kozar, right?
Cozart.
And that's why they put them with hydrochlorothiazide.
Well, hydrochlorothiazide is a diuretic,
Right, but that's why they're.
but they mix them together because hydrochlorothiazide is a blood pressure diuretic. It's not a very potent diuretic to get rid of edema.
Right.
But-
So is that why a lot of the time they're on diuretics as well as?
Because you're trying to treat the causes, and then you're trying to put a Band-Aid on it. Because if you think about this concept, all right? If somebody has fluid here, right? Their pump works, right? But they've thrown a big blood clot here,
And
okay?
and you don't want constriction.
Hang on.
Okay.
Bear with me for 1 second. I know you're excited. I can feel the energy, all right? But bear with me for a second. Somebody's throwing a blood clot here, and they've got a lot of edema, right? So we give them a diuretic.
Mhm.
Is that gonna help?
It's not gonna
No.
fix that, but it'll fix the
Right.
edema.
Is it?
Oh, no, because it can't process.
Guess what? You have now stumbled onto it. What if somebody's got pulmonary hypertension?
It's prior to the block.
It's yep, they've got a big kick here, and you throw a diuretic on here.
It's not gonna get to the other
It's not gonna
side.
get over there. So what's it gonna do to here? What's it gonna do to this area?
Dry
If I
it out.
attach a suction here,
It'll dry
right?
it out.
it's gonna get dried out. And what's gonna happen over here? It's still gonna be puffy.
It's still gonna be all crappy, yeah.
Right. Why do we do that?
I don't know.
Get in there.
Okay.
Okay? Diuretics are a Band-Aid. They don't solve the problem. They're just a Band-Aid.
So are they worth it?
They are because it's a quality of life thing, right? So, but you're fixing with your ACEs, your ARBs, your beta blockers, right? Those are your keys, right? What other medicines do we have in there that we normally take about with heart failure? We can talk about calcium channel blockers.
Yeah.
All right, let's talk about calcium channel blockers. First of all, now we're gonna really.
I'm actually learning something.
I know.
So, remember, we're doing things to offload the pump, right? Do we want the heart pumping stronger or weaker?
Stronger.
Stronger, correct. Now, in the world of calcium channel blockers, you have two classes, dihydropyridines and non-dihydropyridines, okay? Have you heard that term yet?
No.
Okay, then I don't want to complicate things. You have a class of calcium channel blockers that are really great for blood pressure, and then you have a class of them that are very good for relaxing things. Because if you remember in your biology, you have calcium channels that go into the heart muscle that makes the heart muscle contract, right? And if you block those calcium channel blockers, what happens to the contractility of the muscle?
It's not as,
It goes down.
yeah, receptive.
It gets weaker, right? Which is great out here for blood pressure, but if that calcium channel blocker gets to the heart muscle, it's gonna make the heart muscle weaker. Do we want that? No. So calcium channel blockers that affect the heart muscle, but not blood pressure, affect the heart muscle, are contraindicated in heart failure, unless you're treating blood pressure. Like for example, amlodipine or Norvasc, specific just to blood pressure, has no effect on the heart. Procardia has an effect on the heart and blood pressure. Well, we don't want to use that for heart failure. Okay, contraindicated.
So if you don't have heart failure, what will procardia do to the heart besides help with blood pressure?
Not much.
Okay.
Not much of anything. It makes things relaxed. In some cases, you may want that effect, because if you think about this,
It might be working too hard.
well, yes and no, all right?
Uh-huh.
So, all right, I am not the biggest guy in the world, but if I sit here and I have 20 pounds worth of weight and I do this all day long, day in and day out, what's gonna happen to my muscles?
Well, they're gonna get
Fatigue.
strong.
They're gonna get bigger, right? You look at Arnold Schwarzenegger,
Mhm.
right? You look at his early days, how big he was, right? Look at him now, he's still pretty big, isn't he? Right? Do you think he works out as well, as much as he did back then? The muscle's gone backwards.
I don't know
No.
how that works.
No, they don't, because they're still there, they're just not as efficient, all right? Now, if you think about a heart that's pumping against a kink here, or against a restriction there, are the muscles gonna have to work harder because there's more resistance?
Yeah.
Right? What happens to the muscles of the heart when it pumps against resistance day in and day out, year after year after year after year?
Get stretching out.
Oh, they get thick.
I'm tired, yeah.
They get thick, they get bulky, right? So, look at this picture, all right? Here is a normal heart. Okay, what's the volume like? Right?
It's like 100 cc's to me.
Looks like 100 cc's to me, all right? So now look at this.
Was she
Oh, he
thick?
doesn't have much in there.
25.
Right, what's his stroke volume like converted with this guy?
Yeah.
Right, now, remember, cardiac output is stroke volume times heart rate, right? This is 100 cc's times 60 is 6 liters per minute, correct?
Mhm.
This is 20 cc's. What does this heart need to do in order to make up for stroke volume? It's got to pump harder. What happens if you slow that down?
You're not gonna get there.
What's gonna happen to blood pressure?
It's gonna.
Tank.
Okay.
All right? So, left ventricular hypertrophy. Somebody has severe LVH compared with a normal ventricle, they need heart rate, unless you can thin out the muscle. So in these cases, beta blockers, calcium channel blockers are essential to help the muscle relax to increase chamber size.
Okay.
Oh, taking on a whole new appearance, isn't it?
Yeah. Yeah, because I really didn't understand anything about the heart before I came in here.
Right.
To be real honest.
So this is why we use ACE inhibitors and beta blockers. Now let's talk about something that's really gonna freaking blow your mind.
You can do much more of mine.
I'm gonna walk out of here, my head's going. Okay, so we talked about diuretics and we talked about fluid that's over here. Let's talk about your, well, some of you are probably already parents. It has to be one of the, no offense, but the older group that I've had. Usually I get people straight out of high school and I ask them to think about your parents, right? And think about your mom who's had a bunch of kids, right? She's working around the house all day. She's got varicose veins, right? Nobody likes feet and ankle swelling, do they?
Oh, my mom has terrible varicose veins.
Okay, right? Nobody likes them, do they?
Yeah, no.
Right? So let's talk about a few things. All right. So
She literally wears them.
let's talk about diuretics for people who have edema from a right-sided cause. Okay? So it's all fluid that's over here. Well, actually, it could be left or right. Let's talk about over here. Because remember, in order to get rid of extra fluid in the body, we got to get it here. Correct? Everybody agree with that? All right. Now, here is water. That represents the water that you drink and the water that you absorb. Okay?
Mm-hmm.
So now, person's drinking just like normal. That water goes in the body. And it can't go forward. It backs up. Blood clot there, valvular issue there, chronic issues over here, but it's backed up over here. Okay? So now, blood pressure in an artery. There's your blood pressure here. Okay? So systolic blood pressure of an artery, arterial blood pressure. 120?
That's what it should be.
Should be, right? Right, is. Actually, it's a little better than that. Thank you very much. All right, so what is the systolic blood pressure in a vein right before it comes back into the heart?
Oh, I can't remember. Like 60 or 40. It's real low.
Give me a number.
Is this is on the,
I remember going through it and you guys saw what it was.
Right atrium.
I don't know. She literally.
I was gonna say 40.
And I can't remember what it was.
This is important if you're going into critical care. Because those that chart you're talking about is Swan-Ganz catheters, or right-sided heart catheters. And that's how you tell what kind of shock people have. You can tell about fluid volumes, cardiac output.
And that's how you check like the A-lines and stuff, what should be in an A-line?
Well, no, this is a Swan. But either way, we can talk about that later too. So, what is the venous pressure, the systolic venous pressure right before it goes into the heart? Any guesses?
40.
Huh?
That's what I was gonna say.
40?
Yeah.
Okay, so I got a guess of 40. Anybody else?
Come
on.
I think it's probably like 20 or so.
20?
I'm gonna say 15.
15?
We just low. Anybody
Anybody else?
Going once, going twice.
Going once? Twice?
Well,
Okay,
shit.
so what is it?
It's probably
We're having a
60.
5 to 7.
Oh, I was the closest.
You were the closest. Okay?
What do I win?
You. No. I gotta be careful. I don't know you guys from Adam and I don't want to get thrown out. All right. So 5 to 7. So here is a vein. 5 to 7 millimeters of mercury. Okay? Here's tissue. Okay?
Don't need much.
Fluid goes from high pressure to low pressure, correct? So if I have a pressure here of 10, water's going to go which direction? Into the vein. Okay? Now, if I have a backup this way, what happens to the volume in my veins? If it backs up, it increases. What happens to the pressure in the vein if it increases in volume? Pressure goes up. So if I make this pressure 10, now which way is the water going to go? It's going to go out in the tissue, okay? And I'm going to have edema. So now, if I can't mobilize the fluid going forward, if I put a suction on here and I dehydrate my blood when it leaves the kidneys, what's the fluid volume in dehydrated blood? High or low?
Low.
Low. So if I can dehydrate the vein, what happens to the pressure in it?
It goes down.
It goes down, and the fluid now will mobilize back into the tissue. All
I
right.
think this sounds terrible.
Right. So why do you think our patients feel like shit? Right. They're dry, and then you tell them don't drink.
Is that why people, when they get back from dialysis, feel like kind of crappy?
Their blood pressure low because their volume's low. They feel like they go in fluid overloaded. They go in heart failure. They come out in shock.
Right.
They're miserable.
They feel like crap. Can you imagine going in puffy and then coming out in shock in a matter of a few hours? Right? Imagine this person walking around. All right. So think about this. We talk about the meds that we've used so far. We put a beta blocker on them. So what's their heart rate like? Right? So we put a beta blocker on. What's their heart rate like?
Lower.
Lower, right? So when they try and do activity, does their heart rate go up to compensate?
It tries.
No. So what's going to happen when they try and do work? They're going to get tired, right? Now,
That's the problem
their
I
ACE
have with my beta
inhibitor, what's that do
blocker.
to their blood pressure?
Lowers
Lowers it. So now their blood pressure's low and their heart rate's low. And now I dehydrate them and tell them not to drink.
Yeah, you're just setting them up for failure.
Exactly. So why do you think they're in the hospital and a crappy quality of life all the time?
Because
They need some lasers.
Right. So now, if you have somebody who has pure right-sided failure, your mom with the varicose veins, do we give her diuretics? No. What we do is we increase the pressure in tissue. If I increase the pressure in tissue to 15.
So is that why she has compression stems?
Yes.
Yeah, because she's not on a diuretic.
No.
Or fluid restriction.
Right, because we increase because it's not retained fluid, it's just fluid in the wrong place.
Yeah.
If we increase the pressure in the tissue, it drives it back in the vein. We try and get it uphill to where there are good working veins, and now it mobilizes itself.
I love it.
I told you, Cardi.
We don't throw diuretics at these people because all we're going to do is dehydrate them to fix a problem that's not fixable
But
by
how
that.
come we do throw diuretics at
Because
them?
it's a Band-Aid. What you have to do is you give a little bit of diuretics, you give a little bit of fluid restriction, but you have to do good medicine. And you try and fix whatever you can fix. So if they're not getting good fuel, you fix it. If they don't have good spark, you fix it. You get your smokers to stop smoking. You fix their valves if you can, right? You fix their fuel lines so they're getting good fuel supply. You put stents in or you bypass them, right? So you fix as much as you can fix. You treat them with medications and then use your diuretics purely as a quality of life Band-Aid as a last resort.
So I know when you are on, I think it's ACE inhibitors and beta blockers, they need to do frequent BMPs to check kidney function.
We do that only for the ACE inhibitor.
Okay.
Your beta
That's
blockers
what
have
it
no
was.
effect on kidney function
How does the ACE inhibitor negatively affect the kidney?
because it affects potassium levels.
Oh,
What
Because
does it do
potassium-
for potassium?
Because potassium is filtered out by your kidneys.
Right.
And if we're impacting a drug that works on kidney perfusion, because remember, blood flow to the kidneys aren't always happy, right?
Right.
Because now we're not allowing them to get the volume that they need, right? So now kidney function may be marginal. So the kidneys filter out excess potassium. If the kidneys aren't working as well, you get a potassium buildup.
Hyperkalemia.
And now they become hyperkalemic. And then you wind up doing one of two things. Either give them a little extra diuretic to take care of some extra potassium, or you wind up decreasing the ACE inhibitor, or you put them on a thiazide. Actually, you can't do them with thiazide diuretics. That makes them increase it. So all you got is a diuretic, a regular loop diuretic, or you got to back off on your ACE inhibitor. But that's why you're checking BMPs.
You should really think about coming to teach.
Do you have your master's?
I do.
We need better
Really
teachers
good.
at Corning.
No, for real though. Like they only have one.
Seriously.
I have a very simple mind.
You
You
should
got
just come and
This
teach
is
the heart.
just
Like,
water movement, huh?
Yeah, did you do cardiology?
We had a person just come and teach OB, like, you can just come and teach, like.
My worst subjects in school was the female hormonal cycle and derm. Oh, neither one of them make any sense to me whatsoever. You women are just by yourself.
That's me not going to OB.
Wonderful, unique individuals that you are. Okay, but that is